The defining biological signature of Alzheimer's disease is the relentless buildup of toxic proteins in the brain. Specifically, amyloid beta and tau proteins misfold, aggregate, and harden into dense plaques and tangles around neurons, effectively suffocating them. For decades, medical science has approached this accumulation as a strictly localized biochemical problem. The prevailing view dictates that the failure occurs exclusively at the cellular level, right where the plaques form. A new line of research proposes a systemic view. Instead of a purely local chemical malfunction, this model suggests the buildup is actually a macro-hemodynamic clearance failure. Healthy brains do not passively let waste sit in tissue. They possess an active, fluid-driven plumbing system designed to constantly flush these metabolic byproducts away. If neurodegeneration is a catastrophic waste management failure, attempting to dissolve the plaques with localized chemistry might be the wrong approach. The actual solution might require fixing the brain's downstream plumbing. This hidden infrastructure relies on two distinct networks. The glymphatic system moves fluid through the brain tissue itself, while the meningeal lymphatics act as a drainage network built directly into the protective membrane surrounding the brain. Together, these networks function as the central nervous system's dedicated janitorial service, continuously sweeping debris out of the cranial vault. And as this 3D map of the fluid pathways shows, all of that collected waste has to go somewhere. It ultimately drains downward, exiting the skull and funneling into the cervical spine and neck. This precise anatomical exit route is the target of a highly experimental microsurgery known as deep cervical lymphatic-venous anastomosis, or dcLVA. This procedure attempts to reverse cognitive decline through the surgical modification of the physical drainage routes in a patient's neck. To understand how this intervention works, we have to trace the exact route of the fluid. Cerebrospinal fluid is propelled deep into brain tissue through narrow, branching paravascular channels that run right alongside blood vessels. As this fluid pushes through the tissue, it acts as a solvent. It picks up soluble metabolic waste products, including the highly toxic oligomer forms of amyloid beta. The fluid then reaches a critical transition point, crossing over from the internal tissue spaces to enter the meningeal lymphatic vessels that line the perimeter of the brain. From the meninges, this upper pathway makes its final descent, funneling the fluid and its toxic cargo directly down into the deep cervical lymph nodes located in the neck. The entire self-cleaning mechanism of the brain relies on maintaining a continuous, unimpeded physical pressure gradient, a one-way flow from the high-pressure skull down into the systemic circulation of the body. The central mechanical hypothesis driving dcLVA is that these deep cervical lymphatics can degenerate over time, losing their capacity to transport fluid. When this downward flow gradient stalls, as illustrated by the red zones in the schematic, it creates a physical bottleneck. The fluid has nowhere to go, resulting in severe back pressure that pushes back up the entire column. This cervical back pressure translates directly into upstream dysfunction. The stalled flow effectively paralyzes the paravascular clearance channels inside the deep brain tissue. Without a constant flow of solvent, the neurotoxic metabolites stagnate. They precipitate out of the fluid and solidify into dense amyloid plaques. Under this specific anatomical model, the neurodegeneration of Alzheimer's is the disastrous upstream consequence of a clogged drain in the neck. The objective of the surgery is to bypass that congestion entirely by creating a mechanical shunt, routing the stalled lymphatic fluid directly into the high-capacity venous blood system. This diagram maps lymphatic networks in green and veins in blue. For dcLVA, surgeons suture functioning lymphatic vessels to veins, top right. Arrows show fluid diverted into venous flow. Alternatively, LNVA, bottom right, sutures the lymph node directly to the vein, creating a high-volume shunt. Regardless of the specific connection method used, the unified goal is to equalize the pressure differential and restore the brain's primary outflow tract. This dual-axis chart compares preoperative and postoperative cerebrospinal fluid biomarker concentrations from early clinical cohorts. The data tracks notable postoperative drops in both amyloid beta and tau levels in the fluid bathing the brain. Hemodynamic imaging supports these biochemical shifts. Post-surgery ultrasound scans reveal increased blood flow through the jugular veins and carotid arteries, indicating restored circulation. Clinicians are also tracking neurological endpoints using MRI, with scans showing increased post-treatment connectivity in the brain's default mode network, a critical hub for memory. However, these results present a kinetic anomaly. Plaque accumulation takes decades, yet clinical reports show patients demonstrating cognitive improvements just days after surgery. The leading theory to explain this speed is that the surgery does not instantly dissolve the hardened plaques. Rather, the sudden restoration of flow rapidly flushes out the highly toxic, still soluble protein variants and acute inflammatory molecules. The rapid cognitive benefits likely stem from this immediate relief of generalized intracranial pressure and the clearance of the most volatile toxins, rather than a total reversal of the physical brain damage. Despite the promising early data, there is significant skepticism within the broader neuroscience community about whether a physical bypass alters the true trajectory of the disease. This skepticism is rooted in the reprieve hypothesis. As visualized by this mechanical pressure valve releasing built-up fluid, critics argue that dcLVA merely acts as a temporary release rather than a lasting cure. The logic is straightforward. If the underlying systemic cause of the lymphatic degeneration in the neck isn't addressed, the new surgical bypass will inevitably succumb to the same disease processes and clog up as well. Proponents counter this limitation with a practical upside. Even a temporary restoration of flow might allow the brain enough time to halt acute inflammatory damage and provide patients with months or years of meaningful cognitive recovery. Determining whether dcLVA is a true disease-modifying intervention or just a temporary mechanical crutch is now the primary goal of large-scale randomized trials happening globally. This experimental surgery requires a major conceptual leap. It shifts the treatment framework of Alzheimer's away from pure biochemistry and firmly into the realm of applied fluid dynamics. The biological plausibility of the model is sound. The health of the brain's internal environment is inextricably linked to the physical efficiency of its downstream plumbing. To rigorously test this hypothesis, multi-center, sham-controlled trials utilizing advanced robotic microsurgery are currently underway to map exact outcomes against placebo effects. As we pull back from the dense network of neck vessels to view the entire brain system, it is clear that regardless of whether dcLVA becomes a standard of care, the anatomical pathways it targets have established a new structural focal point in neurobiology. The future of treating neurodegenerative diseases may depend just as much on unblocking the body's physical pathways as it does on modifying its underlying chemistry.